Welcome to G Fun Facts Online. Today, we're talking about a monster, a cancer so aggressive, it's named for its multifaceted, monstrous appearance under a microscope. It's called glioblastoma. This is the most common and most lethal primary brain cancer in adults. It's a disease born from the very cells meant to support our brain, the glial cells. It's a grade 4 tumor, the highest grade there is, known for its terrifyingly rapid, infiltrative growth. It doesn't just grow as a single mass. It sends microscopic finger-like tendrils deep into healthy brain tissue. This is why, even after a surgeon removes all the visible tumor, the cancer almost always comes back. The median survival time, even with the most aggressive treatments we have, is just 15 to 18 months. For decades, the one small comfort in this grim diagnosis was the belief that the battle, however devastating, was contained. The brain has a fortress called the blood-brain barrier, a highly selective membrane that was thought to keep glioblastoma locked inside the central nervous system. The spread of this cancer beyond the brain, what's called extraneural metastasis, was considered an extreme rarity, an anomaly. But that paradigm is shifting. A growing body of evidence shows that this brain-bound monster can, in rare instances, break free. And one of its most surprising and brutal targets is the very framework of our bodies, the skeletal system. Today, we're exploring how a cancer of the brain finds its way into bone, what that means for patients, and where hope lies on the scientific horizon. To understand the shock of finding a glioblastoma tumor in a rib or a vertebra, you have to understand its nature. It arises from astrocytes, star-shaped cells that are crucial for brain function. When they turn cancerous, they multiply with astonishing speed. The initial symptoms can be vague: persistent headaches, nausea, seizures, or subtle personality changes. But as the tumor grows and exerts pressure, these symptoms worsen, leading to muscle weakness, memory problems, and a decline in cognitive function. The standard treatment is a grueling assault: surgery to remove as much tumor as possible, followed by radiation and chemotherapy. Despite this, recurrence is almost a certainty. This relentless, localized aggression has always defined glioblastoma, which makes its appearance outside the brain a subject of both clinical astonishment and intense scientific curiosity. So, how does it breach the fortress? How does a glioblastoma cell embark on the perilous journey from the brain to a distant bone? It's a complex odyssey that requires the cancer to overcome multiple biological barriers. Researchers have identified several key steps. First, the cancer sabotages the fortress itself. To feed its rapid growth, glioblastoma triggers the formation of new blood vessels, a process called angiogenesis. But these aren't normal, well-built vessels. They are chaotic, leaky, and disorganized. The tight seals of the blood-brain barrier become compromised, creating a potential exit route. This leakiness is what allows MRI contrast dye to light up a tumor on a scan, but it might also be the gateway for malignant cells to slip into the systemic bloodstream. Next, the cancer cell has to transform. To metastasize, a cell needs to become mobile and invasive. Glioblastoma cells undergo a process similar to what's known as the epithelial to mesenchymal transition, or EMT. Triggered by signals in their environment, like low oxygen levels, the cancer cells shed their static characteristics and adopt a migratory phenotype. They gain the ability to move, to push through tissue, and to begin their journey. Once mobile, the cells need to clear a path. The brain isn't empty space. It's supported by a dense scaffold of proteins called the extracellular matrix. To get through this, glioblastoma cells release a cocktail of powerful enzymes, particularly a family called matrix metalloproteinases, or MMPs. These enzymes act like molecular scissors, cutting through the matrix and clearing a path for the advancing tumor cells. This enzymatic demolition is crucial not just for local invasion in the brain, but also for breaking through the walls of blood vessels to enter circulation. Once a cell is mobile and armed with these enzymes, it has several potential escape routes. The most common is believed to be through the bloodstream. Cells that breach the leaky blood-brain barrier enter the systemic circulation. Scientists have found direct evidence for this by discovering what they call circulating tumor cells, or CTCs, in the blood of glioblastoma patients. Once in the bloodstream, these cells can travel anywhere, eventually getting lodged in the tiny blood vessels of distant organs, including bone. The rich network of veins around the spine, known as Batson's plexus, is a suspected superhighway for spread to the vertebral column. Another shocking route is direct invasion. Groundbreaking new research has shown that glioblastoma can actively erode the skull bone it touches. Using advanced imaging, scientists have documented areas of bone destruction where the tumor creates microscopic channels connecting the skull marrow directly to the brain. This creates a kind of tumor-skull communication superhighway, allowing cancer cells a direct path out. Finally, there's iatrogenic spread. Surgical procedures, while essential, can inadvertently open pathways. Disrupting the brain's barriers during a craniotomy could theoretically allow tumor cells to spill into the bloodstream or surrounding tissues. And medical devices like ventriculoperitoneal shunts, used to drain excess brain fluid into the abdomen, can create a direct conduit for cancer cells to metastasize to the abdominal cavity. But escaping the brain is only half the battle. The cell must then survive the hostile environment of the bloodstream, evade the immune system, and find a hospitable new home where it can take root and grow. The fact that this happens so rarely is a testament to how many barriers are in place. But the fact that it happens at all highlights the terrifying adaptability of this disease. For the small, unfortunate group of patients who experience it, the metastasis of glioblastoma to their bones is a devastating turn. A localized brain disease becomes a systemic one, bringing a whole new set of brutal symptoms. The most common first sign is pain. Not the headaches of the brain tumor, but a new, persistent ache or sharp pain in the back, ribs, or hips. Case reports paint a vivid picture. A 21-year-old man, 6 months after his brain tumor surgery, presented with severe back pain. Scans revealed his glioblastoma had spread to his first lumbar vertebra. A 49-year-old man developed low back pain nearly a month after his second brain surgery. Imaging confirmed metastases in his ribs and thoracic vertebrae. As these metastatic tumors grow within bone, especially the vertebrae, they cause catastrophic damage. They weaken the bone, leading to fractures from minor or no trauma. Even more critically, they can compress the spinal cord. This leads to a cascade of debilitating neurological symptoms: sharp, shooting pain radiating down a leg, progressive weakness in the limbs, numbness, and eventually, loss of bowel and bladder control, a true neurological emergency. This layers severe new physical disabilities on top of the already immense burden of a primary brain cancer. Diagnosing skeletal metastases from glioblastoma requires a high index of suspicion because it's so rare. Imaging is the cornerstone. An MRI of the spine can show tumorous lesions, while a CT scan can reveal where bone has been eaten away by the cancer. A full-body PET scan can light up all the metabolically active cancer sites, revealing the full extent of the spread. But the definitive step is a biopsy. A pathologist examines a tissue sample from the bone lesion. To be certain it's metastatic glioblastoma and not a new cancer, they use special stains. The presence of a marker called GFAP, or gliofibrillary acidic protein, provides strong evidence that the cells in the bone originated from the brain tumor. The prognosis after this diagnosis is exceptionally poor. Survival is often measured in months, weeks, or even days. In one case series, the median survival after the discovery of bone metastases was a mere 25 days. Paradoxically, metastases seems to be reported more often in younger patients and in those who survive longer with their initial brain tumor. The grim logic is that a longer survival period simply gives the cancer a larger window of opportunity to complete its metastatic journey. When glioblastoma spreads to the skeleton, the goals of treatment invariably shift from curative to palliative. The focus becomes controlling symptoms, preserving neurological function, and maintaining the best possible quality of life. Localized radiation to the affected bones, especially the spine, is a mainstay. It can be very effective at reducing pain and can sometimes temporarily halt or even reverse neurological damage from spinal cord compression. Surgery might be considered if a single lesion is causing severe compression to stabilize the spine and prevent paralysis. But undertaking major surgery on a patient with such a poor prognosis is a decision made with extreme caution. Systemic therapies like the chemotherapy agent temozolomide are often continued to try to slow the overall disease progression. Palliative care becomes an absolutely essential component of treatment. This isn't just end-of-life care. It's about managing the immense symptom burden. This includes aggressive pain management, controlling nausea and fatigue, and providing psychosocial and emotional support for patients and families facing a devastating diagnosis. The goal is to preserve dignity and comfort, allowing a patient to spend their remaining time as meaningfully as possible. While the current outlook is bleak, the relentless pace of scientific discovery offers glimmers of hope. Researchers are attacking this disease on multiple fronts. The future of glioblastoma treatment lies in moving beyond the traditional approaches. Immunotherapy, which harnesses the body's own immune system, is one of the most exciting frontiers. One strategy is CAR-cell therapy. This involves genetically engineering a patient's own immune cells, called T cells, to recognize and attack cancer cells. A recent phase 1 clinical trial, using a novel form of CAR-T therapy for glioblastoma, showed dramatic and rapid tumor regression in the first few patients, generating considerable excitement. Another approach is targeted therapy. As scientists map the genetic landscape of glioblastoma, they are identifying the specific mutations that drive its growth. This allows for the development of drugs that target these precise vulnerabilities. For instance, researchers recently identified a pathway called ROBO1, which is normally used in brain development but is hijacked by glioblastoma cells to facilitate their invasion. New therapies are now being developed to block this pathway. Clinical trials are also investigating drugs repurposed from other cancers, like a breast cancer drug called ribociclib, which has shown an excellent ability to cross the blood-brain barrier. And there are emerging forms of radiotherapy, like targeted alpha therapy, which aims to deliver highly potent, short-range radiation particles directly to tumor cells, sparing healthy tissue. Many of these new therapies are systemic, meaning they travel throughout the body. Any therapy that proves effective against glioblastoma cells and can circulate systemically could, in theory, be effective against metastatic deposits in the bone as well. The recent discoveries about how glioblastoma interacts with the skull and bone marrow are also opening up entirely new therapeutic avenues. Understanding how the tumor manipulates the local environment could lead to strategies that prevent this direct form of invasion. Glioblastoma's ability to escape the brain and invade the skeleton forces us to redefine this enemy. It is not always a contained, localized problem. It can become a systemic foe, capable of a brutal campaign throughout the body. The journey from a glial cell in the brain to a destructive lesion in the spine is a testament to the cancer's insidious adaptability. For patients, it's a catastrophic event. But even in this darkest corner of oncology, every case report and every molecular study adds to our understanding. This knowledge is fueling the development of a new generation of smarter, more targeted therapies. The unexpected invasion of the skeleton is a stark reminder of the enemy's cunning, but it's also a powerful catalyst, driving researchers to develop treatments that can finally hunt down and eradicate this disease, no matter where it tries to hide.